ladies and gentlemen, dear colleagues. Let me present you my PhD topic, Prognostic Factors of Serum Biomarkers in Urothelial Cancers. My name is Ádám Széles. I'm a part-time resident and PhD student here at the Department of Urology at Semmelweis Clinic. My vision is therapy optimization of urothelial cancers, and as a mission I would like to assess the utilization of different biomarkers in urothelial cancers treated with immune checkpoint inhibitors. It's just a quick view of my three ongoing projects, so please let me go one by one. My first study name is investigating the prognostic significance of soluble PD-L1 and soluble PD-1 in human malignancies treated with immune checkpoint inhibitors. About the manuscript status, we are currently writing this article. About the background, I think it's out of any question that cancer is one of the most important life burden in today's life, and immune checkpoint inhibitors are a prosperous drug to treat cancer. We are talking about a really hot topic, as you can see here in the two gentlemen who won the Nobel Prize in 2018 for their discovery of immune checkpoint inhibitors. So how these drugs work? You can see here a T cell and a cancer cell, they both expressing PD-1 and PD-L1. If these two receptors binds together, that causes an immune suppression. So if you block it with an agent, immune checkpoint inhibitor, that causes an immune boost, so the T cell will be more likely to kill this cancer cell. This sounds really promising, but what we can see in the reality is that immune checkpoint inhibitors are really effective, but for a relatively small rate of patients. In this meta-analysis, we would like to assess soluble PD-1 and soluble PD-L1, these two soluble versions of these two receptors, if they have a prognostic value in human malignancies treated with immune checkpoint inhibitors. If we construct a PICO framework that will look like this, we have a population of all kinds of cancer who receive this therapy. We're comparing different levels of biomarkers, and as an outcome, we choose cancer-specific outcomes like overall survival and progression-free survival. We did the systematic search in the four following databases with the following search key, and we found 458 articles, and after the selection, we have 16 articles. About the results, here you can see overall survival, and the biomarker is soluble PD-L1. And when we made the subgrouping based on the type of cancers. And what you can see here that the heterogeneity is quite high, but it comes from many reasons, because we are comparing different kinds of cancer, the population, the cohort sizes are quite different. So what are the numbers tell us? We are talking about hazard ratio. If the hazard ratio is higher than 1, that means that high biomarker level is a risk factor. If the hazard ratio is less than 1, that means high biomarker level is a protective factor. Here the overall hazard ratio is 1.67, meaning that patients who have high biomarker level, 67% more likely to have worse survival rates. Here the second outcome is progression-free survival with the same biomarker, and here we made the same kind of subgrouping with the same kind of heterogeneity problem that I just described, and here the overall hazard ratio is 1.20, meaning that patients who have high biomarker level, 20% more likely to progress on immune checkpoint inhibitor therapy. Here we are assessing the changes of soluble PD-L1 levels during immune checkpoint inhibitor therapy. And what you can see here, that the anti-PD-L1 therapy caused a really strong fold change in soluble PD-L1 levels. So what are the strengths of this study? That this is the first study that's assessing these biomarkers in aspect of immune checkpoint inhibitor usage, and we have significant number of articles. However, we have some limitations, that the heterogeneity problem that I just described. We have half retrospective and half prospective studies. The cutoff values were different where they draw the line in these biomarker levels, and they used different ELISA kits. And what we can conclude from this is that soluble PD-L1, it could be a useful pretreatment prognostic biomarker. However, the prognostic value of soluble PD-L1 seems to be different in various cancers, so therefore we should interpret this in a tumor-specific context. And this indicates that soluble PD-L1 might have a cancer-specific prognostic value. The implication for practice is to use this biomarker, and the implication for research is to investigate it in a tumor-specific context, and these on-treatment flare-ups that I just showed you looks like it's therapy-specific, and its clinical and biological relevance needs to be further evaluated. My second project name is high pretreatment soluble PD-L1 is associated with muscle invasion and shorter survival in upper tract urothelial carcinoma. This is a post-hoc analysis of a prospectively corrected serum samples. We have submitted this article and it's under peer review. About the background, that upper tract urothelial carcinoma is a rare disease. It only takes 5 to 10% of all urothelial cancers. And the clinical question behind this article have two separate ways. One is that preoperative biopsy has only a limited value determining the tumor pathological stage, so that can lead to over and under treatment as well. So there's a great need to find prognostic preoperative biomarkers. The second is that in much advanced cases when we have metastasis, we have to give some kind of systemic agent that can be chemotherapy or immune checkpoint inhibitor. So this is a radiotherapy predictive question to choose from this therapy. So the aim of this study to determine the prognostic and or predictive value of this biomarker in upper tract urothelial carcinoma. We have 65 patients in our cohort. We have a surgery group, a chemotherapy group, and an immune checkpoint inhibitor group. We did the analysis with sandwich ELISA. Here, the first result, you can see the association of preoperative serum PD-L1 concentration and clinical pathologic parameters in the surgery group. And what you can see in the box plots, we compare the lower grade versus the higher grades. We compare the non-muscle invasive versus the muscle invasive, and the non-metastatic versus the metastatic. And you can see there is clearly a significant differences in these biomarker concentrations. The next results, here we compared the pre-operative versus the post-operative levels. As you can see, there is a slight but significant increase. In the chemotherapy cohort, there is absolutely no elevation on treatment. And in the immune checkpoint inhibitor, there is a really strong 25-fold increase of soluble PD-L1. And this can be really similar to the previous observation in the meta-analysis. We made a survival analysis in the surgery and in the chemotherapy cohort, and you can see we have significantly worse survival for the high biomarker group patients. The strength of this study is that the cohort size, 65 patients, doesn't sound like a big cohort, but this is a rare disease, so it's not a small cohort. The prospective design of this study, we have different treatment setting, and this is the first article in this project. However, of course, we have some limitation that we could not make a correlation analysis of the tissue level of PD-L1 and the serum level of PD-L1, and the cohort size in the immune checkpoint inhibitor group limited us to don't have a survival analysis so therefore the therapy predictive question, we did not have any answer. About the conclusion is that significantly increased soluble PD-L1 levels we found in the higher pathological stage, and we found association with shorter survival, and this indicates that soluble PD-L1 is a preoperative prognostic biomarker for in upper tract urothelial carcinoma. The indication for practice is to use this biomarker in pretreatment optimization and risk stratification, and these on-treatment levels again needs to be further evaluated. Just a quick view of my third ongoing project, which will be really similar to the first meta-analysis, but this time I will investigate the prognostic significance of neutrophil to lymphocyte ratio, platelets to lymphocyte ratio, CRP and LDH, but this time in urothelial cancers treated with immune checkpoint inhibitors. Bladder cancer is among the top 10 most prevalent cancer in the world, and unfortunately metastatic bladder cancer 5-year survival rate is devastating, below only 5%, and because this is a urothelial cancer, again, we have the chemotherapy and immune checkpoint inhibitor solution for treatment. So the aim of this study to highlight the importance of widely accessible laboratory parameters in clinical decision making. The clinical question, again, it's obvious, it's really similar to the previous one, and if we construct the PICO framework, that will be again really similar, but this time the population is urothelial cancers who received immune checkpoint inhibitor, and the clinical implication is to use these, again, widely accessible laboratory parameters in clinical decision making. We did the systematic search, and after we submitted the first meta-analysis, we will start this project. Just a quick view of my 3 ongoing projects, and thank you your kind attention with the words of water that I disapprove of what you say, but I will defend to the death your right to say it. Thank you very much.
I would like to ask that, do you know what is the reason why immune checkpoint inhibitors don't work in every kind of cancers, just in specific ones? What is the biological background of it, if you know?
Well, that's a great question. This is what everybody asks about immune checkpoint inhibitors. First of all, there is the tumor mutation burden. We think that the higher the tumor mutation burden is, the better the immune checkpoint inhibitors work, because there are more neoantigens and our immune system can work better if there are more antigens. So that is one. But in these studies with the big clinical trials, they didn't find a clear independent value for the tumor mutation burden, that if it's higher than a cutoff level, then okay, for everybody it will work. For example, there is a PD-L1 in the tissue level, so not the soluble one, because that's right I am assessing, but there is the tissue level. Of course, we can say for example, non-small cell lung cancer, for urothelial cancer, if there is a certain limit that higher the tissue PD-L1, we give that. So this is a predictive biomarker. But within those groups, there is only, for example, in urothelial cancer, 30% of patients who respond to that therapy. So this is actively investigated topic.
Thank you very much.
I would like to ask, is there any previous criteria to start such a PD-L1 therapy in urothelial cancer? For other cancers, there are immunohistochemical reactions you can check on the cell surface to, guess the tumor mutation burden. Not know, just to guess. Are there any previous exams need to be performed for urothelial cancer to start this therapy?
In urothelial cancer, PD-L1 testing.
So PD-L1 testing in the tissue? Or?
In the tissue, but we are checking immune cells in the tissue.
Okay.
So in the tissue, you can check the cancer surface, and you can check also the immune cells in the tissue.
Okay.
So for example, in non-small cell lung cancer, they use the tissue proportional score, but it's different for the immune checkpoint. For example, atezolizumab and pembrolizumab, these are different criteria.
Okay. But you said you had no PD-L1 from the tissue. In the lecture. You said you had no PD-L1 from the tissue, just
in the cohort study, we didn't have the tissue example, the tissue samples. So that's why we couldn't make a correlation analysis. The higher the tissue level, the higher the. So.
Thank you very much.